So we're in the hospital now, I think, and what I'm doing is I'll just go through this. There's another version of this talk which is entitled "Nurses Run Hospitals and Doctors Mess Them Up," I might tell you why in a minute, but you probably know. Now, I did spend nearly 6 years doing the National Clinical Director thing, and I was lucky, and sometimes not so lucky, to travel around all the DHBs, and see how things were done. And what I did is I published this is a viewpoint paper, which means it's not science, it's opinion. I published my experience and opinion in this viewpoint paper, which I think was attached to your agenda, so you're welcome to do with that as you like. But essentially what I'm going to tell you now is from that paper. So it's what I saw around the place, cobbled together. This place, in fact, doesn't exist, but it's the elements that I thought were pretty good from lots of different places that I saw. So here we go. So that's the problem, which we're very familiar with, of course, a crowded emergency department. And in simple terms, of course, demand exceeds capacity. Now, I'll talk about demand and capacity quite a bit, and I'll fall into the usual trap of describing demand as people and capacity as beds. But it's not that. It's much more complex than that. The capacity issue, which is often the biggest constraint, is decision-making capacity. And the demand, every demand unit, every person is different in terms of the demands they have. They've all got, for our safe staffing people, they've all got their own sort of acuity levels, which we can sometimes measure. Some of us do very well with trend care and other devices, and some of us don't. Some of us measure it very well and then largely ignore it. So that's another problem. So demand and capacity, so it's not a bed count and it's not a head count, but I'm going to use that. So when demand exceeds capacity, of course, we form queues. And the queues could be for any of those resource constraints. So it could be for cubicles, nurses, doctors, CT scans, operating theatres and all those things. And of course, if you get a queue somewhere down the journey, then you'll start to get backing up at other points in the journey as well, so you get queues for other components. So when we get a queue, of course, we get a backlog. Now, this is all very straightforward, but it's actually fundamentally incredibly important. So now we've got a backlog, which means that what we couldn't cope with before, which is still coming through the door, now in addition to that workload, we've got the workload of a backlog as well. So the queues get longer and the backlog gets bigger. And now we need to cope with all of that stuff. We weren't coping before with the capacity we had, the demand was coming in, and we've now got increasing backlog. So we go down the spiral of doom. And that's what we do every winter. Sometimes we do it every morning, and I'll go through some of this stuff, but we have a bad winter, a bad start to winter. Maybe it's only a week that's bad, but it takes us 3 months to get out of it, because we've gone so far down that spiral of doom, it takes a hell of a lot of effort to go back up, and I'll explain some more of that in a minute. Worse still, and one of the reasons we're going down the spiral of doom is that queues themselves are bad. So queues, independent of the stuff that form the queues themselves introduce their own delays, and we know this, and that's an example, of course. If you're stuck at the lights, you're the 10th car back and the lights go green, so capacity is now open, you won't get through simply because of the queue. The time it takes to process each of those cars means that you will miss out on that resource. The same happens in just using the beds and patients analogy. We've got 5 patients in the ED and 5 beds become available. It'll take 2 hours to get that 5th patient upstairs, simply because they're in a queue. So queues are bad. Queues introduce their own delays over and above the capacity and resource demand constraints we've got already. So it sends us further down the spiral of doom. There are lots of pictures of the spiral of doom. And we know all these things, and I won't go into this, but we know these things are very bad. And they're bad not only for patients, they're bad for staff, and they're bad for the bottom line. They cost more money. We're burning money by doing this. So patients are going to the wrong beds, and maybe we're cancelling electives as a consequence, maybe not. But at the very least, we've got long ward rounds, therefore delayed decision making. And in fact, we've got delays at every stage of care. So delay getting them off to theatre means they're going to stay longer. Delay getting the antibiotics into the pneumonia patient means that patient's going to stay longer. So all of these things are compounding, so we go down the spiral of doom. So all of these things are additive. So we had a single capacity demand resource imbalance, capacity demand imbalance, which has now contributed and compounded like interest in the bank and pushed us all the way down. So queues are evil. We must avoid queues at all costs, and they're bad for those things which I mentioned already. Queues are evil, and that's my sort of take-home message. We must avoid queues at all costs, because queues are incredibly counterproductive in terms of efficiency and use of resources. Now, this is for dummies, because I've got a very simplistic approach to this, and my apologies to those who are much more into operations and queuing theory and all that sort of stuff and know much more about it, but this is my take on it. So here we have a hospital. It's not one of yours. I could have chosen one of yours or one of ours, but it's a fictional one. You might recognise it. And there's a population of patients. So there's a capacity and a demand. This is demand, and that's capacity. Now let's assume that the capacity of this hospital is 50 units of whatever, and we'll stick to the beds thing. Let's say there's 50 beds in there, and your average daily demand for beds is 50. Obviously it goes up and down, but the average is 50. Then of course you're going to have demand exceeding capacity half the time. So half the time you're going to be forming queues. Now the other half the time you won't be, but once you go down that spiral of doom, it takes a hell of a lot longer to get up than it did to go down. So that half time of grace is insufficient to have a balance and to recover. So this is a compounding situation. So clearly that's not sufficient resource. If on the other hand we were to look at the top of the demand curve and get a resource that matches that, so not the middle, not the average, but the top, then we will have capacity exceeding demand, or at least at worst matching demand, all the time. So we would never form queues, which would be fantastic, but of course that's never going to happen, because our capacity would be redundant quite a lot of the time. It wouldn't be used, and that's something we can't tolerate. There's a lot of argument about redundant capacity and buffer zones and things, and we should have 15% empty beds and all that sort of stuff, which I'll talk more about. And this is, so that's probably extravagant. So 50% is too low, 100% is probably too high. So the answer is somewhere in the middle in terms of what capacity we should have in relation to demand. And there's all sorts of figures, and I'm not going to go into the maths of this, mostly because I don't know it. But there's all sorts of figures that people use, and people often talk about in hospitals 85% capacity. Some people say the 85th percentile plus a proportion of that is where you should have your capacity for that level of demand. The bottom line, and then there's all sorts of arguments about, well, what is a capacity unit? Do we include PEDS beds and ICU beds, and do we measure it at midnight or all the time and then average it and all those sorts of things? And we get lost in the argument when the point is this. When a patient needs whatever the resource is, it's available promptly so that they don't get into a queue, because queues are evil. So that's all that means, all that capacity stuff, that's all that means, that we can get to the next bit of the resource promptly so that we don't form queues, or if we do see queues forming, we sort them out pretty quickly so they don't get too big. Now, so the reality is that most of us, and we measure this stuff, occupancy and things, and also other measures of capacity. I am focusing on the bed issue, but please, this applies to everyone, to everything. Maybe CTs or nurses or senior doctors or whatever. But most of the time, our capacity and demand curves follow each other very closely, and sometimes one goes above the other and so on. When we get a bit of capacity exceeding our demand, we think it's Christmas. And we say, oh gosh, this is quiet. It's not quiet, it's efficient. We're getting through much more work, shorter length of stays, better outcomes. We're getting to tea, we're getting to have a pee when we need to, doing all those things that we should be doing, therefore we're working more effectively. But we call it quiet because most of the time we're not in that space. So how do we stop queues developing when capacity and demand run so close together? We need a very responsive system, and a responsive system has two elements to it. It recognises when this is happening and then it responds to it. Now, I'll go through the model in a second, but we've become pretty good at recognising stuff, but less good at responding to it. I don't know if it happens in your place, probably not, but Friday afternoon you're in the ops centre and you think, gosh, it's going to be a terrible Sunday, see you Monday. And that's the response. There isn't one. So we need both of those arms, obviously. So this is the model that I suggested. And it's a conceptual model of a structure, and I'll just go through the elements of the structure. And a lot of people have alluded to the fact that sometimes very good ideas don't work, and there was a desire a request to share those ideas that don't work. And I can't remember, someone mentioned that it may be the contextual elements of that not working in terms of the culture and so on. And that's absolutely correct. If you pick off the shelf something from the NHS or something from the DHB over the road and implant it into a fallow field of opportunity for change, either because the culture or the engagement or the infrastructure or the ownership or the surrounding support for that isn't there, then it's just got to go. And it's a double whammy. Not only have you not achieved something, but you've also lost some goodwill from those who were briefly engaged. So you really need to get the structure right, the foundation right for change. And I'm just going to talk about that. So in the centre of this, the patient journey, in the paper itself, it goes through all of these wee arrows and what they might represent. But essentially, the centre of this sort of concept is that we've got a longitudinal journey through a system, which was mostly designed, as you well know, in vertical bits, vertical silos. And we've got to a situation in our evolution that we need to sort out the bits in between. So that's how we consider this. We look at the journey, or the journeys, the many journeys. But there are elements on that journey that would be the expectation, the standards of care. So it may be at the front that the referral processes are sorted out as to whether GPs phone, fax, or just come in. There's a process which is accepted by the system. There's nurse-initiated interventions of various sorts. There's pathways or clinical agreements, incredibly important. It's absolutely ridiculous that we have a 70-year-old lady turning up with chest pain and non-specific ECG changes 10 times a day, and we've got 5 different ways of managing it. She either goes home, she stays in the ED, she goes on telemetry, she goes to CCU, she has a second troponin and goes. That's ridiculous. It's the same patient. We must standardise our care. Front-loaded decision-making. If your ED consultants are not out front more than they used to be, then you're behind the times. Expected date of discharge, daily rapid rounds or assertive ward rounds, all that stuff. Planning for discharge, not just in your flash medical wards with the innovative physicians, but also in ENT and surgery and orthopaedics, everywhere. It's a standard of care. If you're not doing it, then you're behind the times. Pathways, I mentioned, fast-track pathways. I think everyone's got a fractured neck of femur pathway. If you don't have a fractured neck of femur pathway that works, then your system is negligent. That's well below the standard of care, and we should be applying the same methodology to everything else. To have an old lady with a broken hip languishing in the ED, waiting for an orthopaedic registrar to come down and give a papal blessing, someone should be shot in your institution if that's the case. It just should not happen these days. And so on, all the way down to the discharge, the nurse-initiated or criteria-based discharge and so on. So there's a bunch of stuff that we know now that's proven to be good, not proven in a very strong evidence base, but it's proven to be good, this stuff, so we all should be doing it, and we all should be doing it everywhere. The other bits, the governance. Lots of good ideas, not joined up, and we've had these comments before, not joined up. What is the scheme of things? We don't have a scheme of things. How do I fit in the scheme of things? I don't know, because there is no scheme of things. The structure, what's the structure? What are we trying to achieve? Who's in charge of it? Who's the authority? Who's represented? My people are represented. I'm involved in this. I'm going to get engaged because I see my boss or my colleague in amongst it. It's supported by management and by process improvement groups. There's a methodology applied to it in terms of the data gathering, how we analyse the data, the value stream mapping, whatever it is you want to do. There's a methodology to work out what are we going to do first, and then a plan which is comprehensive and prioritised and planned. It seems a redundant thing to have a planned plan, but it's important to have a planned plan. In other words, who's in charge of this particular action? When's it going to be done by? How do we know if it is done? How do we know if it's worked or not? So these things are followed through, very action-orientated. There's a zillion things to do in each of your hospitals. If you sit of people in a room and say, let's make a wish list of things we need to improve, you'd have over 100 elements. You can only do 5. Which 5 do you do first? Those 5 you need to get to work on and get them finished, and then work on the others. I cannot see any of the stuff we're talking about working if it's not in the context of that engaged structure that drives it, makes it happen, joins it all up. Operations, daily operations we're very keen on. And this is the sort of the operational part of the governance part, obviously. So this sort of underpins all of this work. So we've got the patient journey in the middle, but the operations is the control. And we're getting on to that. All of us have, I think someone asked the question earlier, do we have operation centres or control centres? And I think everyone nodded. And some of them are quite flash. And some of them are useful, but they're not the same thing. And you know, your daily bed meeting, and you have a look at all these screens and you think, well gosh, there's a A lot of stuff going on over there. How many people have a doctor in the room during your operations? And your daily bed meeting? You do? Yep. Who do you have? What sort of person? In Auckland? Yep. What sort of doctor comes?
We will have a doctor from general medicine usually.
Yep.
General medicine, registrar, attend their meetings, but we have a weekly forum as well where
Right.
we have up-to-date material.
It does seem extraordinary to me, and I didn't see any other hands, so I presume that's the case. It seems extraordinary to me, coming back to the concept of nurses run hospitals and doctors mess them up. The operations of hospitals, the patient movement, the use of beds and things, it's a nursing, it's fallen under the nursing umbrella, and lucky it did. Whereas it's the doctors who actually make decisions about who's coming in, who's going home, how long they're going to stay, when they need this operation and all that sort of stuff. It seems extraordinary to me that the general surgeon of the day, the physician of the day, the cardiologist of the day, and whoever else you've got who is contributing to running this organisation for this 24 hours is nowhere to be seen in terms of operations, and they don't speak to each other. They have no idea what the state of the hospital is. That's obviously a generalisation. But it seems extraordinary to me that those leaders of a day's activity in a complex, resource-poor, demand-rich organisation would not have a presence. And good. Good. Excellent. Yeah. And that's the way we should be going. I think every person in that institution is a citizen of the institution, and no one is bigger than it or independent from it. If they're working in your hospital, they belong to it, and they abide by the rules, and they do what they're told. And that should apply to your neurosurgeon, your orthopaedic surgeon, and everyone else. Nobody is bigger than the institution, and that's a culture that we need to push. Okay, a little bit about this stuff, matching capacity and demand. Now, if we discover that we've got a capacity and demand problem, then we need to do something about it. Medium to long term, e.g. winter planning as we're discussing now, short term daily operations, and crises, sort of the three elements of capacity and demand management. So medium to long term, we've got very good tools. Some of us use CAPLAN, other of us use TrendCare isn't really designed for this, but it does do prediction. CAPLAN's designed for prediction, but it doesn't do acuity modelling. I think you need both. I think all of our DHB should have both because they do different things. So we can predict with great accuracy in the high 90% what's going to happen a week, a month out, what's going to happen on Monday to our hospital, which is important. And then we need to do something about it, which we'll come to in a second. Short term, so we can see right now what's happening with the hospital. We're in the operations room and we can see what's going on. And then we're turning into custard. We're starting to form queues. How do we solve that? That's a crisis one. So we need three plans. We need three bits of work in relation to this. Of course, the crisis one, which we're all heavily into, less than we used to be, we went through the colour spectrum, didn't we? Because as we got greater levels of gridlock, we dropped green and then yellow, and we added purple and black and other things at the other end. So it became the new normal. But I think we're working our way back up the rainbow, hopefully. But this crisis stuff should become less and less common if you're doing the other two right. What are the options? If demand exceeds capacity, of course you can reduce demand, or we can free up capacity by improving processes. I'm going to talk more about smoothing, number 3, in a second. Haven't got much more to do. Or we can buy more capacity, or all of the above. And the answer, in fact, is all of the above. And one of the mistakes we've made over the years is we sometimes put all of our egg thought baskets, thoughts in one egg basket, egg thoughts in one basket, and get blinkered, mixing my metaphors, get blinkered by one of these options. So we really get stuck into acute demand management. It's incredibly important, but not at the expense of some of the other things necessarily. Similarly, we may say the secret's process improvement. No investment until you sort out your flow and your models of care. Good point. I have yet to see a DHB hospital here or anywhere in the world where they've embarked on more than one of these things and at the end of the day they've had too much capacity. It's not happened. We can do this in parallel. We must do it in parallel with a bit of a leap of faith that all of the above is necessary. A wee bit about smoothing demand, because this is something we can do relatively cheaply, not necessarily easily. This is my, I'd like to thank the graphics department for this illustration. You'll recognise those two curves. This could be anything in an acute hospital. On the x-axis, That's time of the day, we'll say, time of the day. And this could be ED capacity, it could be people waiting for beds, it could be acute theatre, it could be lots of things because they follow similar curves. But essentially we're quietest in the morning, so this might be 7 a.m. 10 a.m. typically we start to climb. This is a typical day in the ED. 10 a.m. capacity, occupancy I should say, climbs. And it reaches a peak about 2 p.m. Stays at that peak till 10 p.m. and then drops again. So got the 10 to 2 to 10 curve. And that's a typical curve. Obviously it varies a little bit from day to day, but it's a typical curve of demand. That's a demand curve. Here's a supply curve, which is the beds that these patients are going to go into. And because we know this, people get discharged a little bit later in the day by the time they actually walk out the door and the bed is available for the next patient. Now that may not seem a big problem, but over that time period we've got demand exceeding capacity, so we've formed a queue. Now this probably would never happen in your hospital, but there's a bit of a fight with a duty manager or someone. Said, look, we've got people building up in the ED, people building, and you're told to keep your knickers in a twist because there's beds becoming available at 5. And your response should be, wrong answer, you stupid woman. Queues, man. We've developed queues, and now that we've developed queues over 4 hours, it's going to take us 8 hours to get back up that spiral of doom. Queues are evil, and we need to understand that we must avoid queues at all costs, and a process which is responsive is necessary. Okay, a little bit about this daily smoothing, discharge before the admission surge. Now, we've all tried 10 a.m. discharge or 11 a.m. discharge in our hospitals with variable success. Some success, but variable, but it is an important thing because otherwise we get that mismatch. Weekly smoothing. I don't know if this still happens in any of your places, but we know what our acute demand days are, our biggest acute demand days. We know that Monday is pretty busy and tends to have the highest admission rate to hospital, so the greatest need for beds. We know that Sunday is also pretty busy and tends to have the least beds available in the hospital. Sunday is busier with different things and often has a lower admission rate for most EDs because it's more of that minor stuff. But let's just work on the Monday bit. So on Monday, we've got the greatest demand for beds, but there are the least beds available because we've done no discharges over the weekend. And then if you superimpose on that your elective surgical admissions, because you've got a theatre list on Monday and Tuesday, then you've got a problem. And it's a problem of your own design. It can be fixed. We know when our acute demand is, and that should be when we are not doing our elective demand. Same with seasonal stuff. Most of our elective activity occurs in the winter. Quarter 1, quarter 2, and then in the summertime, of course, we do none because everyone's on holiday, when our acute demand is least. So we superimpose because it's convenient for us, sometimes to do with funding cycles and targets and things as well, but because of our own making, we superimpose elective demand on our uncontrollable winter, well, not necessarily uncontrollable, but our peak of acute demand. We can fix that, not easily, but we can fix it. And we must fix it. We must have it, and this is where the structure comes back. To be able to fix these things which are outside acutes, they're outside the ED, they're outside medicine, they're a much bigger picture, we need that authoritative structure, but we can do that. So that's that. That's it. There's a little bit more detail in the paper if you want to read it, but that's my thing. Thank you. Good work there.